Today's topic is Antimicrobial Stewardship Program. All of you know what is stewardship, careful and responsible management of something entrusted in one's care. You can see this is a navy, the person who is entrusted with the food, mercantile food. So he is a leader. The stewardship is a leadership in the particular sense. So what is the definition of stewardship? An antimicrobial stewardship program is a coordinated effort to optimize the use of antimicrobial agents, aiming to improve the patient outcomes, reduce antimicrobial resistance, and lower healthcare costs. Antimicrobial stewardship program is a systematic approach to promote appropriate use of antimicrobials, including antibiotics, antifungals, and antivirals. So antifungals and antivirals is a further step, but presently and there are so many hurdles. So now at least antibiotics, if you implement and gather appropriate experiments, you can go for antifungals and antivirals. Now, this is an interdisciplinary approach. Antimicrobial stewardship program involve collaboration among the various healthcare professionals, including clinicians, pharmacists, microbiologists, and infection control specialists. What are the key principles? Evidence-based. So always there should be evidence-based background for reference. There should be continuous monitoring and evaluation whether our program is going on the right track or not. Education and training, time to time education and training is necessary so that the refreshment of the knowledge will occur. And patient education is also very important. Patients sometimes emphasize that I want to antibiotic, but it may not be necessary. So in that case, the patient education is helpful. We can convince the patient that antibiotic starting is not necessary at that point. Then advantages, improved patient outcomes, reduce antimicrobial resistance, and lower healthcare costs. So these are the advantages of antimicrobial stewardship program. Then how is the governance or implementation of antimicrobial stewardship program in any hospital? Various committees are there. So first and foremost is the leadership, healthcare setup, facility leadership has to take the initiative or take the lead for formulating the antimicrobial stewardship committee. The collaboration between the drug and therapeutics committee, then patient safety committee, and infection prevention and control committee, along with the antimicrobial stewardship committee, is essential because it will go hand in hand. It's not a single one person's work. So they should go in coordination. The microbiology lab will give the supporting documentation or evidence for particular drug resistance. So antibiotic policy, formulating antibiotic policy, and another thing is giving the timely report to support or to guide the patient's appropriate treatment. Then AMS team and AMS champion, these are the two words or two people who will volunteer for this antimicrobial stewardship program, and they will be the front end workers who will go for an audit, antimicrobial stewardship audit, and give the appropriate feedback. The cooperation between the surgeons, medical practitioner, then pharmacists and nurses with a antimicrobial stewardship committee or antimicrobial stewardship team is very essential. So this is particular flowchart shows how is the organization structure of antimicrobial stewardship program. So administrative support is important. Then formulating AMS team, then infrastructure support. Whatever the infrastructure required, for example, improved diagnostic setup, improved blood culture, IDAST, or molecular methods for rapid diagnosis, it is necessary. Then it should give the investment should be done and by the leadership, by the head of the institute. Then framing antimicrobial policy, it is done by the microbiology department based on the previous data, and accordingly the time to time the policy should be revised and released so that it will act as a evidence for giving the empirical antibiotic treatment. Then implementing antimicrobial stewardship strategies, we have to go for monitoring and surveillance. Time to time we have to monitor whether the effective efficacy of the program, it should be monitored. Education and training, time to time the education and training should be conducted, and feedback and audit should also be conducted. So these are the various aspects of implementation of antimicrobial stewardship program. Now WHO has released the aware group of antibiotics. So what are those aware group of antibiotics? We'll see in the next slide. So access group includes antibiotics or antibiotic classes that have activity against the wide range of commonly encountered susceptible pathogens while showing lower resistance potential. So they are having lower resistance potential than the antibiotics and than in watch and reserve group. Access antibiotics should be widely available, affordable, and quality assured to improve the access and promote appropriate use. The selected access group antibiotics are given here, which are included in WHO essential medicine list as an essential first choice or second choice empirical treatment options for specific infectious syndromes. So, what are the SS antibiotics? Amikacin, amoxicillin, amoxicillin clavulanic acid, ampicillin, benzathine benzyl penicillin, then cephalexin, then cefazolin, chloramphenicol, clindamycin, cloxacillin, doxycycline, gentamicin, metronidazole, nitrofurantoin, phenoxymethylpenicillin, procaine-benzatyl penicillin, spectinomycin, sulfamethoxazole trimethoprim. So these are the access group of antibiotics. It should be always available so that there should not be hindrance for implementation of the antimicrobial stewardship program. Now come to the watch group of antimicrobials. So this group includes the antibiotics or antibiotic classes that have higher resistance potential and includes most of the highest priority agents among the critically important antimicrobials or human medicine or antibiotics that are relatively high risk of selection of antibacterial resistance. Watch group antibiotics should be prioritized as a key targets for national and local stewardship programs for monitoring. So selected watch group antibiotics are shown here, which are also included in the WHO essential medicine list. So what are those antibiotics? Azithromycin, cefixime, cefotaxime, ceftazidime, ceftriaxone, cefuroxime, ciprofloxacin, clarithromycin, meropenem, piperacillin tazobactam, and vancomycin. So watch group antibiotics. So high risk of selection of bacterial resistance is there. So this is the target for modification. Here we should be very vigilant when you are starting. There should be justifiable reason for starting those watch group of antimicrobials. The reserve group includes antibiotics or antibiotic classes that should be reserved for treatment of confirmed or suspected infections due to multi-drug resistance organisms and treated as a last resort options. Their use should be tailored to highly specific patients and settings when all alternatives have failed or not suitable. So whenever you are starting reserve group of antibiotics, you should ask yourself that whether watch group of antimicrobials are total options are exhausted or what. So they could be protected and prioritized as a key targets of national and international stewardship programs involving monitoring and utilization reporting to preserve their effectiveness. So selected reserve group antibiotics are shown here. They are also included in EML, that is emergency medicine list. So when they have favorable risk benefit profile, so we have to analyze risk benefit and depending upon that it should be advised. Then against critical priority or high priority pathogens identified by WHO priority pathogens list, notably carbapenem resistance enterobacteriaceae. So what are the drugs of reserve group in aware classification? Ceftazidime, avibactam, colistin, fosfomycin, then linezolid, meropenem, valproatam, plazomicin, and polymyxin B. So what are the 9 common areas for improving the antibiotic prescribing? Over prescribing, you can see the examples. Antibiotics are prescribed when not needed. Fever without evidence of infection, asymptomatic urinary tract colonization, or viral infection, malaria, inflammatory conditions. So there is a over prescription. Then overly broad spectrum use. More broad spectrum antibiotics watch or reserve antibiotics are prescribed than necessary. that is during the surgical prophylaxis. Unnecessary combination therapy, including certain fixed dose combinations. Multiple antibiotics are used, particularly with overlapping spectra and combination that have not been shown to improve the clinical outcomes. Wrong antibiotic choice. Wrong antibiotics are prescribed for particular indications or infections. Wrong dose. The antibiotics are prescribed with the wrong dose, overdosing or underdosing. Wrong dose intervals. The antibiotics are prescribed with long dose intervals, too much time between the two doses. Again, it will lead to the development of drug resistance. Wrong route. Antibiotics are prescribed by wrong route, that is IV instead of oral. Then wrong duration. Duration of antibiotic treatment should be optimized, that is antibiotics prescribed for long period or prolonged surgical prophylaxis. Then delayed administration. Administration of the antibiotics is delayed from the time of prescription. Repeat doses are not in the timely way, which is a critical in case of septic shock or other serious infections. So these are the 9 common areas of improving antibiotic prescribing. Now, what are the strategies of antimicrobial stewardship program? There are two strategies: front-end strategies, which includes formulary restrictions, and back-end strategies, which includes AMSP audit and feedback. So first we will see the front-end strategy, that is formulary restrictions. You can see the restricted antimicrobials, semi-restricted antimicrobials, and unrestricted antimicrobials. So what happens is the restricted antimicrobials, what we should do? Pharmacy supply of more than 1 day requires prior approval by the antimicrobial stewardship team. For example, colistin, carbapenem, tigecycline. So these require prior approval from the antimicrobial stewardship team. Then semi-restricted antimicrobials, pharmacy supply for more than 3 days requires prior approval by the AMS team. For example, teicoplanin, vancomycin, daptomycin, linezolid, third and fourth generation cephalosporins. So these are the semi-restricted antimicrobials. If supply more than 3 days is necessary, there should be approval from the antimicrobial stewardship program. Then unrestricted antimicrobials, pharmacy supply does not require AMS team approval. So these are the unrestricted antimicrobials. First and second generation cephalosporins, no problem. They can give cotrimoxazole, azithromycin, clarithromycin, fluoroquinolones. So these are the unrestricted antimicrobials. So formulary restrictions, if you consider in toto, there is a role of pharmacy. So communication with the pharmacy and antimicrobial stewardship program is very important before dispensing the drug to the patient or patient relatives for administering in the patients. Now come to the back end strategy. It is difficult to perform and it is most effective strategy to implement the antimicrobial stewardship program. The AMS team goes for stewardship round, during which they discuss with the clinical team in detail about the compliance to the antimicrobial policy and mutually agreed upon the constructive decision between the AMS team and clinical team. Now, there should be a positive interaction between the AMS team and clinical team. So there should not be any argument, because the clinician will be the front, he will be facing all the patients. So AMS team, so how we should come with a positive outcome? By discussing constructively. The clinician should take as constructive criticism, and AMS team also should project that matter with a positive words. So they should come to one conclusion, which should be mutually agreed upon. So here the communication skill of AMS team members with the clinician is very important. Then if you analyze the back end strategy, it is more labor intensive, more widely practiced, more easily accepted by the clinicians. If you just politely say, this is something, please, can you revise, doctor? So, proper words, polite words will lead to the modification of the strategy of antibiotic administration. It provides higher opportunity for educating and training healthcare professionals. So, day in and day out, if the AMS team is visiting the critical care areas, they will also come to know that there is something which is a sensitive matter. Administrating the antibiotic is a sensitive matter, and These people, they are reviewing the antibiotic administration. Then impact is delayed, but it is a sustainable. So back end strategy, it is there. Now come to the hospital antibiotic policy. So what do we mean by hospital antibiotic policy? It is a data of resistance among commonly encountered pathogens, both in community and hospital settings, patterns of resistance to newer antimicrobial agents, recognition of new trends of resistance, selection of antimicrobial agents should be based on sensitivity reports, treatment of common infections should conform standard regime, it retards the emergence of antibiotic resistance and it avoids wasteful expenditure of government and non-government organization. So what a hospital antibiotic policy will do, it will give some evidence based on the previous reports, and it will give the base against which the further recommendation what empirical antibiotic therapy is given in particular disease conditions. So what is done here, antibiotic policy, the data in microbiology lab, bacteriology lab, the data of previous antibiotic susceptibility pattern, it is compiled together in different clinical syndromes. It may be pyogenic infection, or it may be respiratory infections, it may be blood culture. So depending upon that, data is generated which will give clue for the future patients what antibiotic empirical antibiotic treatment can be given. So that is called as hospital antibiotic policy. Then come to the AMSP audit. AMSP team visits ICU, review the indications of empirical treatment, see whether there is a switch over to narrow spectrum once the report is available, antibiotic sensitivity report is available, and what was the duration of therapy, what was the dosage, and all the things. What are the 9 mistakes what we have seen? So it will review whether there is any pitfall in that therapy and give the feedback. So the feedback to the clinicians. So these were the wrong things. Wrong, I can't tell, but these were little bit pitfall. So modification is done accordingly. Modification is done, and then escalation and de-escalation of antibiotics, whether it is done in timely manner or not, or whether the prolonged treatment is given. All these will be seen in the antimicrobial stewardship audit. Now, role of microbiology lab. Role of microbiology lab, already we have seen antibiotic policy. Then role of microbiology lab provides the antibiotic sensitive data so that quick switch over to the narrow spectrum antibiotic use. Specific treatment is done so that the patient will get rid completely from that infection. Avoid prolonged and empirical antibiotic therapy. So their promptness in the reporting is very important. Automated methods are helpful here. Automated blood culture methods, automated ID and AST system is very helpful to give the accurate and timely result. And then markers, sepsis markers, procalcitonin, sepsis marker also helps for timely diagnosis of the sepsis and antimicrobial treatment accordingly. So we have to hit the target by utilizing the microbiology lab services. Then here another last point is rational use of antimicrobials. So here some examples are given here. So examples, avoid overlapping spectra. So here it is given meropenem and piperacillin tazobactam combination is given for double gram negative coverage. It should be avoided as both are the beta-lactam group of the antimicrobials. So meropenem and piperacillin tazobactam combination. Meropenem and metronidazole combination therapy for suspected gram-negative or anaerobic sepsis should be avoided because meropenem itself will cover the anaerobic infection, as meropenem is active against anaerobes in addition to gram-negative bacteria. So that combination should be avoided. Then metronidazole in such cases, above case, can be withdrawn from the therapy. Metronidazole we have to withdraw from the therapy when you are starting meropenem. Then come to ineffective antibiotic cloxacillin. Now cloxacillin MRSA is ineffective. Therefore, it should be avoided. And vancomycin is a drug of choice for MRSA. Then inferior antibiotic. Vancomycin is an inferior cell wall acting agent compared with cloxacillin for MSSA infection. So these are some examples. There may be so many combinations also, as and when it will encountered in the clinical practice, it may be revealed. So such rational use of antibiotics should be followed so that unnecessary use of antibiotic is avoided. Now, the last slide, take home message. So antimicrobial stewardship is a multidisciplinary approach. It includes involvement of the administrators, involvement of all heads of the department, involvement of nursing staff, duty doctors, patient safety committee, hospital infection control committee, then drug and pharmacotherapeutics committee. So it should be it is multidisciplinary approach and teamwork is expected here. And it is not a one-day process, or we can't achieve the 100% results on day one. So it is an ongoing process. We have to the process also involves self-analysis, strength, weakness, analysis is there. And in case if there is a pitfall in the protocol of our procedure, we have to go for kappa, corrective and preventive action, and we have to continuously improve ourselves. And the clinician who is using prescribing antibiotics should always be always should be aware group of antibiotics which is prescribed by WHO. So we have to follow those aware group of antibiotics and always think before starting any antibiotic with the patient, is it really necessary? If you do the risk benefit analysis, if it is really beneficial for the patient, or is it really avoid complete the risk on the patient. So with this, I would like to conclude my class here. So thank you for your patient listening. Thank you.